Ooh, things are weird. All right, I think I got it. Hello, women's health students. How's everybody doing? Everybody hanging in there? Cool. Okay, let's pick up where we left off last week. We were talking about integrative medicine. And ideally, all of you all have watched the new medicine. What did you all think of that? What did you think of that?
Cool.
Feedback on it? I want you to have kind of kept in mind some of the case studies and some of the integrated medicine interventions that they did for the different patients that were featured in the and kind of keep that in mind. We'll talk a little bit about interventions for women to help them in healthcare today. Somebody is unmuted with some sound going on in the background. Can you all check and see if that's you? But feel free to unmute if you've got comments or questions. Okay, it went away. Okay, we're good. Okay, does this look like where we left off at the last class? Okay, so biopsychospiritual model. And now we're going to talk about integrative healthcare interventions that deliberately honor women and their unique needs. So we've already talked about their unique needs. So let's move on and talk about how we can be helpful to them. So I teach this in my health psychology class. I've adapted it for this women's health class, but this is Friedman et al. And it was published in Health Psychology. And it lists 6 different pathways whereby psychologists or other allied healthcare professionals, so it could be physical therapists, it could be physicians, it could be occupational therapists, do these interventions. They intervene and they do a treatment that improves the quality of life for their patients. And quality of life is the ultimate healthcare outcome. It reduces costs, which is good because we've got finite amount of money in the healthcare system. And all of these are targeting the demand for healthcare. And so what that means is that if we can do these interventions and we can improve the quality of life for women, women will not necessarily need excessive levels of healthcare. Okay. So let's go into the first pathway. Most of us, when we have illness, we treat ourselves. Okay. Many of the women here in this class, Ash, bear with us, know what it's like to have painful menstrual cramps. And most women do not go to the doctor every month to see their doctor just because they are experiencing menstrual cramps. They treat them on their own, usually with something like Aleve or Motrin. Usually does the trick for most women. And so it's the idea that if we have the right information, sometimes we can treat our own illness without having to access healthcare. Okay. And this is one of those places where the better the education, oftentimes the better individuals are capable of self-care and treating themselves. So one example is that new parents get very, very nervous when their babies run a fever. And oftentimes individuals, if they have not been educated on what a fever is about, will take their child to the pediatrician anytime the child has a fever, or if it's after hours, take their child to an emergency department or an urgent care every time a child has a fever. In this one particular study, what they did is they took new parents and they randomly assigned them. And we're going to see that kind of model through a lot of these studies. They randomly assigned them. One group got nothing special and the other group got an intervention. And the intervention was they educated the parents about fever. They educated the parents and let them know that a fever is a really good immune system response when a baby has ingested some kind of pathogen, so some kind of germ. And then the immune system kicks in and the body raises the temperature because a lot of germs cannot survive at a higher body temperature. They can survive at the normal body temperature, but not a higher temperature. Second thing these young parents needed to know was that kids can tolerate a higher fever than parents. And then the third thing that they let these parents know was how to take a thermometer and check their child's fever, but then also how to treat with an appropriate dose of liquid Motrin for their baby based on their baby size. And I can tell you from experience, when my boys were babies, they're not babies anytime recently, I could hold them, and with the bottle that had liquid Motrin in it, you could feed that baby that liquid Motrin through a bottle and just feel that fever drop. It works really, really quickly. Okay. What they found was that the new parents who got the information versus those who didn't have the information were a lot less likely to take their child to the doctor every time they had a fever. Okay. I'll tell you my story. I had some friends that every time their kid had a fever, they went to the doctor, they would go to the emergency department. And that was not my style because I had the right information. But when my son Forrest was little, my mom had called one morning before I went to work with some updates about a family wedding kind of thing. And she just asked very quickly on the phone, how is everybody? And I said, oh, Forrest is not feeling very well. And she said, put him on the phone. So I put this toddler on the phone to his Nana, and she asked him how he's doing that day. And he said, oh, Nana, my heart hurts. And what he's trying to say, he'd been coughing that night. And so his chest was a little bit sore from his cough. And then I hear my mom go, put your mom back on the phone. So I get back on the phone with my mom. She's like, you've got to take him to the pediatrician. And I was like, oh yes, I've got to take him to the pediatrician. And it was one of those, like, I'm feeling like I'm a bad mom because that wasn't my plan for the day and all this kind of stuff. And it's like, I make the appointment, I rearrange my work schedule. I take Forrest into his pediatrician. Pediatrician checks him out and says, this seems viral to me. There's really nothing we need to do. If he gets a fever, give him Motrin. And if he keeps coughing, you can give him this kind of cough syrup kind of stuff. But there's not really nothing that we can do. And so it was a waste of time, basically. Taking him to the doctor that day was a waste of time, but my mom told me to do so and made me feel guilty as a mother. And so that's why I did it. Okay. The second example here is the telephone counseling example. And some insurance companies still do this. And I really wish that I would have had this kind of counseling help when my guys were little. What they did here is they randomly assigned people that had this particular insurance. They either got nothing special, or their intervention was they were given a telephone number that they could call day and night and talk to. Usually they were speaking with a registered nurse, and they would describe what they were going through in their illness or their kid's illness. And then the nurse would use different kinds of algorithms and would look up information and would guide the person on the phone whether or not they needed to access healthcare or if they could self-treat at home. So if it was an example of a baby with a fever, say of 102, the nurse would counsel them on what kind of dosage of Motrin to give their baby based on the baby's weight, that kind of thing. And then would say, if the baby does this, this, and this, then you need to take them to the pediatrician. In other situations, they would have people call in where, like, an elderly woman calls in and says, my husband is complaining of pain that started in his foot and now it has gone up to his knee. The nurse asks certain questions and finds out this husband has cardiovascular disease. And in that situation, the nurse would say something like, I want you to hang up and call 911 for an ambulance because you've got a roaming blood clot coming up, probably climbing up his leg, that type of thing. So questions here. If we've got the right information, a lot of times we can self-treat. Nowadays, sometimes individuals get themselves paranoid because they're looking up symptoms on the internet. But in a lot of situations, we've got that information available to us. We can look stuff up and we can self-treat a little more than we used to. Questions here? Okay. Treating stress. If stress makes us sick, and the next lecture that we're going to roll over to after this intro, and we'll get to that today, we're going to start talking about stress and stress management and coping. If stress makes us sick, wouldn't it make sense that we treat stress, help people manage their stress more effectively, lower their stress levels, and then voila, they become healthier? Okay. And traditionally in our healthcare system, we have not been very good at training frontline healthcare workers in helping patients manage their stress. And in fact, we talked in the last class about how a lot of physicians are overusing antidepressants because that is oftentimes their go-to treatment for when people are complaining about stress. And ideally, What I would prefer to be happening would be a referral to a counselor or a psychologist where they could get one of these evidence-based therapies that not only help them treat their stress now, but they give them skill sets so that they can continue to manage their stress more effectively, even in the future. The antidepressants don't necessarily do that. They might treat a person's sense of stress right now, but they actually, having used antidepressants, makes individuals more vulnerable for relapse, at least in the depression literature, more vulnerable for relapse in the future. Whereas if an individual does one of these talk therapies, they tend to gain skill sets and have less relapse in the future. So cognitive behavioral therapies, abbreviated CBT, interpersonal therapies, abbreviated IPT, acceptance and commitment therapies, which is called ACT. There are mindfulness interventions and exercise interventions. There are all kinds of ways that we can help individuals better manage their stress and then feel better mentally and then feel better physically from that. So any questions about any of these? Okay. Behavior change. So we emphasized during the last lecture how many of those leading causes of death pre-pandemic were related to lifestyle behavior. So people with sedentary lifestyle, not exercising, people smoking cigarettes and using tobacco products, individuals not eating healthfully, those types of things, as well as now during the pandemic, behavior is everything in preventing us from becoming infected. And so with this regard, and again, if individuals who are experiencing stress go and seek a psychotherapy, that psychotherapy is oftentimes going to focus on getting them engaging in healthy lifestyle behavior, changing their behavior to keep them healthier or to treat illness. Okay, so we do a lot of this kind of thing. The fourth pathway is the social support pathway. And before I get into talking about the doula here, I want to back up and I want to talk about a very powerful effect that we see in the field of health psychology. We know that the greatest predictor of a person's happiness is actually emotional intimacy in close relationship or close relationships. Okay. So emotional intimacy is very important in people's health and happiness. And we know that people that feel that emotional intimacy, they feel that connection. It could be a connection with a romantic partner. It could be connection with family, parents, children. It could be connection with friends. People who have that connection are much healthier than people who feel isolated and alienated, and especially compared to people who feel isolated because of social rejection. That's the worst. Okay. And so we know how important social support can be in our lives. But also as healthcare providers, we want to think about how can we best provide social support to our patients to help them maximize their health. And here's just a really good research study that has shown this. So doulas, they're usually women who have been trained to meet with a woman when she's pregnant, prenatal visits, but then she also attends the birth and does things to support the woman while she's in labor and delivery. And I just want you to keep in mind, a doula is not a midwife. Midwives actually deliver babies and provide medical care. The doula is not a obstetrician who is a medical doctor trained in prenatal care and labor and delivery and that type of thing, delivers the baby. The doula is just an assistant. And the doula does things like rub her lower back if she's having contractions in her lower back, feed her ice chips, help her breathe, make phone calls to family members and give them updates, just whatever that woman needs. The doula caters to her while the midwife or the obstetrician deliver the baby. And if we know, and we talked about this the other day, how much more frequently we in the US are performing C-sections relative to what the World Health Organization says we should be doing and reducing the delivery of C-sections. So very common surgical procedure. And usually women undergo a C-section if the labor gets prolonged. One of my former students just had a baby, and her baby ended up getting born via C-section because she pushed for 4 hours and that baby had not come out. And it's like, oh, 4 hours. I pushed and they were out like within 10 minutes. So I can't imagine going through that for 4 hours, how exhausted you would be. So in this study, they took these pregnant women, they randomly assigned them. The women in the control group just got the delivery from the midwife or the OBGYN. But the individuals that got randomly assigned to the experimental group, they had somebody delivering the baby, but they also had a doula assigned to them while they were in labor. And what they found, these are some amazing results. It decreased the request for an epidural, which is anesthesia that they inject in your spinal cord in your back. I had an epidural for both of my pregnancies, and it sounds really horrifying thinking about a needle going into your back. But boy, I can tell you, mine took really well with my firstborn. My secondborn, the epidural didn't really work very well, but I was so close to delivering anyways. But it's really nice to not be feeling those contractions and just really focus on bringing your baby into the world. But it decreased the request for that anesthesia by 85%. These women were dealing with their pain more effectively, and it reduced their labor by 2 hours, shaved off 2 hours of time that they were in labor and delivery, meaning that they were relaxed and they were using their energy to allow their cervix to dilate, and they were using their energy to push that baby out, as opposed to using their energy to deal with the pain of the contractions. It decreased the rate and need for C-section by 56%. So these women with the doula were a lot more likely to have a vaginal delivery than the women without the doula. And it also decreased the need of babies needing to stay 48 plus hours, which are usually babies who've had complications. So some beautiful effects by just having the doula. And at the time of the study, the doula cost about $200 to have her in the room attending to the woman. So pretty amazing effects. I did not know about doulas back in the day when I was birthing babies, but boy, I wish I did. I wish I did, and I wish I'd had one for both of them. Questions? Okay, very powerful effect of social support here. Fifth pathway is when an individual has an undiagnosed psychiatric or psychological disorder, and in their distress for their psychological disorder, they're accessing healthcare, trying to get support, trying to get help. But when it's undiagnosed, that individual falls through the cracks of the healthcare system. Okay. So meaning, like, let's say they go to their doctor because of insomnia, but the real problem is insomnia as a symptom of major depression. Major depression is quite treatable with those different therapies we talked about a minute ago. Okay. If you can get somebody correctly diagnosed with depression to a psychotherapist who does one of those therapies, you're going to be able to help them. Okay. If their insomnia gets just like, okay, you've got insomnia, I'm going to give you sleep medication, but they don't ask the right questions to diagnose the depression, then their depression is probably not going to get treated. Does that make some sense? So they're falling through the cracks of the healthcare system. Okay. So let's talk about Claudia's thesis. She did this years ago. Dr. Kurt Michael was her thesis chair. I was on her thesis committee. Her husband, Claudia's husband, was an ER physician. And so she had access to a listserv where she was able to push her study out on a listserv to a bunch of ER doctors who were academic ER doctors. And she created these vignettes. And in one of the vignettes, you had a patient that had major MDE is major depressive episode. So in half of the vignettes, the patient had depression. In the other half of the vignettes, the patient had panic disorder. And then she also varied if the patient was a male or a female. Okay. She randomly assigns these vignettes, pushes them out to these ER doctors who complete the survey, and they read the vignette, and then they take a look at the medical tests that were ordered, and then they take a look at the medical test results, and all of the medical test results came back negative. So as an example, let's say an ER physician would take these symptoms of this patient in this vignette and suspect that maybe the patient's having a heart attack. So then they would order these tests, and keep in mind that whatever test they ordered that came back would say, no, they're not having a heart attack. Okay. So there was nothing medically going on with these patients. Okay. And Claudia's dependent variable was, after they read the vignettes, they saw the negative medical test results come back. They had to make a diagnosis, and then they had to create a treatment plan. And what she found was only 72% of these ER doctors correctly diagnosed the depression, which means 28% of those hypothetical depressed patients fell through the cracks and didn't get a referral for their depression. She found only 33% of the panic disorder patients got correctly diagnosed, meaning almost 70% of them fell through the cracks. Okay. And so in this particular emergency department example, again, these were hypothetical patients on vignettes, but a lot of the psychological diagnoses were not getting diagnosed. And if they don't get diagnosed correctly, people are not going to be given the interventions or the treatments that can treat those psychological disorders. Okay. The flip side of that kind of decision error that sometimes happens by physicians in medical departments is when women do present when they're having a heart attack, they are oftentimes given a psychological diagnosis that this is anxiety or this is panic, or Freud called it hysteria. And I don't know if you all know the roots of Freud's hysteria, but Freud believed, and he was trained as a physician, so I don't know how he could have been quite this ignorant back then. But again, he was a man and not a woman. He believed that hysteria, when women would get crazy emotional, was because their uterus would get dislodged and their uterus would travel around the body, and wherever the uterus got lodged, they would have symptoms. So if it got lodged in the back of the head, the occipital lobe, the woman might go blind. And there's no like medical reason for her blindness other than this moving uterus kind of thing. Got it? Now, by today's standards, is that true? Do women get emotional because their uterus travels around their body and gets clogged up somewhere? Of course not. But the terminology lives with us today. When women have their uterus removed surgically, if they've got some kind of horrible issue, you think we would call it a uterusectomy, but we don't. We call it a hysterectomy. Yeah. So the word term has lived with us. It stayed with us. That's why we have a hysterectomy when it really would make more sense calling it a uterectomy. Now, we do know the American Heart Association has been tracking this, and there's a whole program, Go Red for Women, trying to educate women that heart disease and heart attacks are the #1 cause of death, again, pre-pandemic. But typically cardiovascular disease death rates have been higher in women than men. And that, we talked about this a little bit the other day, that is because first responders, as well as emergency department healthcare providers, tend to do less of those diagnostic tests and less aggressive treatment for women compared to men with the same symptoms. One of the things that trips them is, again, thinking anxiety is causing the symptoms and not suspecting a heart attack. The other thing that trips individuals, though, also is when men are having a heart attack, they're more likely to report pressure on their back and radiating pain down their left arm. But just because of the way women are wired, women are more likely to experience gastrointestinal symptoms. Okay. And the gastrointestinal symptoms oftentimes throw doctors, and they think, oh, this is a stomach bug, or this is nervous, like a nervous stomach, again, coming from the hysteria kind of stuff. But less likely to report some of the symptoms that men report when they're having heart attacks. This is especially true for women of color when they're accessing healthcare and they're having a heart attack. But American Heart Association and researchers have been tracking this. There is more awareness nowadays. And so this gap between how effectively we treat women who are having heart attacks is decreasing, but there's still a difference between men and women. Okay, questions here? Okay. The sixth pathway is somatization disorder. And somatization disorder is when an individual fears and feels medical symptoms in their body that have no medical explanation. Okay. And if you know somebody who's really sensitive in their body, really sensitive to symptoms, that might be somebody with somatization disorder. And these individuals are frequent flyers in the healthcare system. They go and get a lot of medical care. They go and get a lot of specialty care. They oftentimes, like these big teaching hospitals, where they get a lot of attention from these younger doctors who think they're discovering a brand new kind of illness, that kind of type of thing. And we know that women tend to have more of those somatization disorders than men. Some of that is rooted in the fact that women are more likely to have been a victim of interpersonal violence. And one way of kind of thinking about what happens sometimes to some of these women, if their body has been violated with physical violence or with sexual violence, oftentimes these women either have like violence memories embedded within them physically. Women who have been victims of violence oftentimes do not engage in the same kind of self-care. And women who have been victims of violence, unfortunately, are actually more at risk for future violence, because there's a little bit of this sort of sense that violence is kind of normal, as opposed to somebody who's not been victimized. If somebody were trying to victimize them, oftentimes they would be like, oh, I'm out of this relationship if you're going to treat me this way. So it's really sad what we oftentimes will see happening to women. So this is Amaka Ima. She was my honors student this past year. She's now in medical school, and she wants to become an OBGYN. She'll be a wonderful one. We looked at, with college women, if they had been victims of polyvictimization. And polyvictimization is when you have a history of more than one form of interpersonal violence. So it could be you were a victim of verbal abuse and a victim of rape, or it could be victim of dating violence. So we've got the sexual violence, the verbal violence, we've got the physical violence. When individuals have had more than one form of violence, that tends to usually be associated with poor mental health, compared to just one form of violence. That's poor mental health in a person who has zero interpersonal violence in their histories. Okay. And because women are more likely to be victims of violence, this is why this is a feminist issue and why we're talking about it in this class. She found that the college women who had polyvictimization versus the college women who had either just one form or zero forms of violence in their history had more somatization disorder, and they had more suicidal ideation. Okay. And so, meaning polyvictimization is really associated with psychological disorders that manifest themselves physically in individuals, as well as suicidal ideation is certainly an extreme risk factor for individuals based on this history. So again, from a feminist perspective, in my mind, I was reading up this morning on articles on how interpersonal violence, domestic violence has increased since the pandemic. And we know this because of individuals reporting it. We know this from previous pandemics like Ebola and Zika and that type of thing. And so very sad. We probably have a lot more children and individuals being abused in their homes right now. We do know that in terms of some of these somatization disorders, fibromyalgia is when people it's almost like when you get a fever and you feel achy. Many of you have had that experience. That's how people with fibromyalgia, when it kicks in, they will have these really tender points and these really achy points all over their body surrounding, and these tender points surrounding their joints. Women have more chronic fatigue than men, and women are more likely to have irritable bowel syndrome, where they get either frequent diarrhea or frequent constipation. And we know for those evidence-based therapies that we talked about earlier are helpful for individuals with these medical-like conditions. I've worked with quite a few individuals that have had these conditions in my clinical practice, and I just treat it as, believing their diagnosis and not questioning their diagnosis at all, but noting how stressful it would be to have any of these things. And then we focus in the treatment on stress management. And for a lot of these individuals, the more effective we are at bringing down their stress levels, learning how to cope with their disease more effectively, the better off they end up being. Okay. Questions here? Okay. So that is it for the introductory lecture. Let me stop my share and let me move over to the stress lecture. So any comments or any questions? Has what we've talked about so far in class fit with what you saw in the New Medicine documentary? Kind of reinforcing, you saw some case studies and you saw some champion psychologists and champion physicians in the New Medicine. And what we're going to be talking about today is going to be a spinoff from some of what you saw in that documentary also. So let's talk about stress and how stress affects health. And let's first go through some semantics or some language here. When people talk about stress from a psychologist standpoint, they're talking about multiple things. So we're going to take this and divide these into 3 different terms. So we would call the stressor the event or the situation that can lead to stress. And if individuals can possibly identify their stressor and avoid it or alter the stressor, it can make things different. I'll give you an example. It used to be when I taught back in the before time, when I would actually teach in the classroom, whenever we would have a snow day and I would miss class, I would fret terribly about what to do with my students and what to do with that lecture because I had never taught online before. And it's just so funny. It's like, boy, have I gotten over that. Like I have learned how to cope with not being able to be in the classroom with students and how to teach beyond that. But I still look back on those snow days and I go, I would get so stressed out about that. And now I probably never will again. Stress perception is what's unique. So what could be stressful for one particular woman might not at all be stressful for another woman, even though the same kind of stressor is occurring. Because this gets filtered through that which is unique to us. It gets filtered through our automatic thoughts, how we're always talking to ourselves in our mind. It gets filtered through our beliefs. Our beliefs could be like rules that we were raised with. Our beliefs could be like religious beliefs that we hold in our faith. And then this gets filtered also through our values, kind of our sense of what we value and we respect in our lives. And it's the stress perception when people are experiencing too much stress that we oftentimes want to get in there and alter their automatic thoughts. We call that cognitive restructuring in cognitive behavioral therapy. We take particularly negative, irrational thoughts, and we try to help individuals create sometimes more positive ways of thinking, but a lot of times even just more neutral, accurate ways of thinking, more logical, more rational ways of thinking about problems. Because a lot of people get into these thought habits where they have a lot of negative, irrational thoughts that are spinning out stress, spinning out psychological disorders, spinning out medical illness. And so this is really going to lend itself to CBT. It might lend itself to interpersonal therapy, might lend itself to ACT therapy. But in this situation, we're helping people change their stress perception so they're not experiencing as much stress. Okay. Okay, stress response would be that fight or flight or freeze response that we get physically. And this is where stress really takes its toll on our bodies physically and mentally. And knowing that we've got lots of different tools to help people alter their stress response. As an example, we know people who exercise on a regular basis do not have the same physical response to stress compared to people who get no exercise in their lives. We know that individuals who learn how to meditate, who learn how to engage in diaphragmatic breathing as a meditation technique or stress management technique, experience a lot less of that toll on their physical bodies. Okay, so A lot of times, again, let's say a psychologist gets referred to them, a medical patient, like we talked about in the last slide, like irritable bowel syndrome. We get in there and try to help them manage their stress levels better. When they're able to do that, their bodies are better able to heal themselves, and they experience a lot less of those medical symptoms because of this. So what I'm getting at, from a healthcare provider perspective, if we can determine what are the stressors in a person's life, how it gets filtered through their stress perception, and we can help mitigate their stress response, we can tackle stress at a variety of different levels to help people. Any questions about that? Okay. All right, let's talk about Hans Seyle. He talked about and first discovered, and this has continued since way back when he was doing his research, and modern day times, it's still very applicable. He called our stress response a general adaptation response. General meaning the way our bodies respond to perceived stress is generalized. It's the same in Sarah as it is in Amanda, as it is in Peyton. Those are the folks that I'm seeing on my screen right now. The physiological response is the same, and it was meant across human evolution. And keep in mind, the amount of time that our ancestors were evolving as Homo sapiens is a huge amount of time compared to our recent contemporary issues and stressors that we have. And the response was all about mobilizing energy, all of it, mobilizing energy. Okay. And that allowed our ancestors in evolution to either flee, saber-toothed tigers you're out picking berries in the field, and there's a saber-toothed tiger that sees you and then starts chasing you for energy, gives us the energy to flee. It might give us the energy to fight. If somebody is pushing us and assaulting us, we might have the energy to be able to mobilize and fight back and protect ourselves. And then in some individuals, there's even a freeze response. It's kind of like playing possum type thing, where an individual becomes paralyzed and they can't move. I can tell you that very sadly, I have worked with some victims of rape who during that traumatic event, they froze, which is actually adaptive, because for some individuals, if they were to fight, they would end up being beaten up and harmed worse. But I've worked with a lot of these individuals who, because of this freeze response, felt this tremendous amount of self-blame and guilt, which is uncalled for. It makes some sense to me. But we need to understand that this response is a normal response to those kinds of threats. Now, the problem with this really helped us survive evolution. It helped us, get past these threats, to be able to stay alive, to be able to reproduce, to pass our genes down through the generations. And so it makes sense, as we pass down these genes, people who had this response that was very quick and very dramatic were more likely to survive threats, were more likely to pass those thrifty, very quick response down into the genetic pool. Got it? So if you are wired to be kind of high in stress and reactivity, you can blame that on our ancestors, okay? Because it was very adaptive across human evolution. The problem with modern day stressors, like think about you're taking a calculus exam and you're blocking on how to solve certain protocol in calculus. If you get that fight or flight or freeze reaction during that situation, it is not going to be adaptive at all, because you're not going to be able to think straight, calm yourself, concentrate, and complete that exam. Okay. So basically what I'm getting at is our mind and bodies have evolved to have this, but in modern day stress, it tends not to be adaptive at all. And in fact, this physiological response, if we have it over and over and over and over again in response to stress, it really takes its toll on our mental and our physical health. Okay. I've got only one event in my life where I had this response where it was adaptive to me. I could name 1,000 times this stuff has happened to me where it has not been adaptive whatsoever. But the one time it was, I'll tell you this story. It was the summertime when I lived in a house and I had a yard that I would mow. I enjoy mowing. It's very meditative. I don't know what it is about the mowing experience, but I find it to be very relaxing. And it had rained a lot that summer, and the grass was really high because it had not stopped raining where I could get out and mow. And finally the rain stops. And I go out to mow that day, and I note, it's like this quick little note to self, wow, the grass is really wet. Note to self. Okay. In the yard that I had at that point in time, I would come down this little hill on my tractor, and I would have to do a dramatic 90-degree turn in order to stay in my yard and not go over this cliff face. And the cliff face was this dramatic, like cliff kind of thing. And then at the bottom of the cliff was a paved road. Okay. So I'm out there in my tractor. Okay. It's a tractor I inherited from my dad. It was pretty badass. It had a roll bar and it had a belt, and it was just, and it could go like 40 miles an hour. I could like speed mow. So anyways, I'm out there and I'm going down that first hill, and I realize I'm starting to move really fast. Okay. I hit my brakes on the tractor, and at that point in time, the wheels lock up because the brakes work. This is why we have anti-lock brakes in our car. The brakes lock up, and now I'm sliding down the hill and building up speed and momentum. I did not even have to think. Without even thinking, this response kicks in. I unbuckle my belt and I launch myself. I jump from the runaway tractor. I launch myself onto the ground, in which I sat there for about 10 minutes going, thanking God that my life was still alive, but just like, woo, I had that fight or flight or freeze response. Okay. So that's just an example of how quickly that energy can mobilize and potentially save somebody's life. You hear about parents lifting up a car off of a kid. That kind of amazing strength can come from this. So questions here. I really want you to absorb that what we've inherited from evolution in contemporary days tends not to be adaptive and healthy anymore. Okay. Okay. In this general adaptation response, one way of thinking about this is what would happen with chronic stress over time. Initially, when we get that response, it's all about mobilizing energy. Okay. But after our energy's been mobilized, if the stressor goes away, then we get to go back to normal and we're fine. Okay. If the stressor continues, then after we've mobilized all this energy, then we hit this resistance stage. And in the resistance stage, all that energy that we've mobilized into our muscles for movement gets depleted. We've spent too much energy and that becomes depleted. But in the resistance stage, initially, our body is going to increase its energy use in our immune system. So our immune system temporarily upgrades. And if you think about evolution, like if we were out picking berries in the field and the saber-toothed tiger, across the field sees us and starts chasing us, not only do we need our energy mobilized to try to flee and get to safety or to fight, we are likely to get injured. Okay. We are likely to get cut. We are likely to get injured. It would make some sense in terms of evolution that we would have this temporary increase in our immune system because we're probably going to need to fight off some kind of infection. Okay. Now we've mobilized energy and we've used energy, and now we have mobilized the immune system and we have used that energy. And if there were two things that I kept with my study of physics in my life is, first of all, everything falls at the same rate of gravity. And the second thing I remember from physics is you can't create energy out of nowhere. Okay. So if our body has a finite amount of energy and we have used it to mobilize movement, and now we've used it to increase our immune system, now we're going to be depleted. We're going to get exhausted. Okay. And it's in the exhaustion phase that many of us feel intense psychological distress. And it's in the exhaustion phase that many of us become physically ill. And there are individual differences in what people physically experience. Some people get migraines when they hit exhaustion. For me, I learned over time, particularly before I got my tonsils removed, if I was experiencing intense stress and exhaustion and had 2 bad nights of sleep, I would wake up the next morning with a sore throat and a sinus infection. Okay. Some of you may get stomach aches. Some of you may get back pain. But many of us have some kind of physical symptoms that occur when we hit that exhaustion stage. So questions here. Okay. One way of thinking about our body's responses and the desire for physical homeostasis. So homeostasis would mean our bodies ideally are staying nicely in balance. And we have evolved some really cool homeostatic types of responses over time that keep us healthy. Okay. But there's two kind of competing responses here. Anabolism is when the body is building and rebuilding itself. And so that would be things like our endocrine system keeping nice feedback loops. That would be things like when we get an injury, you can see over time in the injury, the scabbing, the immune response when it gets inflamed, and then you see the scabbing heal up over time. There would be all kinds of cells replicating and rebuilding when we have external injury. Our cells are always replicating. They replicate less slowly as we age. So young people tend to heal up quicker than, say, really old people tend to heal up. But most of this anabolism is happening, the body healing and rebuilding itself during times of non-stress. And most of our anabolism happens for us at nighttime when we're sleeping. Okay, that's part of the physiological need for sleep, is that our body's at rest, our metabolism lowers, and then there's lots and lots of healing going on while we are sleeping, which is why when people have poor sleep, they tend to get sick. Okay. And one way that as a healthcare provider, when we get in there, when people have a lot of stress, we're always screening for the quality of their sleep. And there's a lot of stuff, particularly using CBT therapy, that we can do to help people improve their sleep. Okay. So this is happening during rest, non-stress, and it's happening during sleep. Catabolism, on the other hand, is what we talked about just a minute ago, is happening during exhaustion. Okay. Our body's used up all its energy. It starts breaking down our cells to get energy. Okay. That's a bad place to be in. So that would be like if we were out lost on a trail and we didn't have food for days, our body would start eating ourselves. It would start with our fat stores first. If we ran out of fat stores, then it would start eating our own muscle tissue for energy. Okay. Another example right here would be if you've ever felt so stressed that it made you vomit. That is your body saying, hey, we need to mobilize energy here. Your body's saying, I don't have the energy for digestion right now. So as an example, some people get an upset stomach when they're stressed and they vomit. Some people get diarrhea when they're really stressed. That's the body saying, hey, I don't have time for digestion. That's a luxury. Right now, I need to use all my energy to help you mobilize and move and fight these threats. Does that make some sense? So can you see how if you've got too much stress and your body's pushed into exhaustion, pushed into catabolism, how bad that would be for both mental and physical health? If we're not getting enough non-stress, if we're not getting enough rest, if we're not getting enough sleep to allow ourselves to heal. Can y'all relate? Can you relate this stuff to some of your lives and what you go through at times? Okay. Yeah, we're all humans. We've all had this. Okay. So one way of thinking about this fight or flight or freeze response, it is the sympathetic nervous system kicking in very, very quickly. Like I said, without even a thought, when I was on that sliding tractor, I was able to get out of that belt and get off that tractor immediately. And it did. It crashed into the pavement. That was a bad day. So this response here is all about mobilizing energy. So our heart rate's going to increase, our respiration is going to increase. That's going to allow us to send blood and send oxygen more quickly to the muscles to move. The opposite of that sympathetic nervous system response is called the parasympathetic nervous response. This is what kicks in when we are not stressed, when we are resting, when we are sleeping. But we can deliberately learn the skills to kick in the parasympathetic nervous system in order to, this is all about healing. So it would be things like allowing for digestion. It would be things like allowing for sexual response. When we are, it's no wonder that a lot of times individuals have sexual dysfunction when they are severely stressed. It makes a lot of sense to me, because if they're stressed, their sympathetic nervous system is dominating, and we need parasympathetic nervous system to be dominating in order to become sexually aroused. So this is fight or flight or freeze. And then parasympathetic is oftentimes abbreviated rest and digest. Okay, rest and digest. Now, a take-home point that I want you to know here is that we are wired with evolution for the sympathetic branch to kick on really quickly. We are not wired from evolution to just kick in very quickly the parasympathetic nervous system. And in fact, it takes skill and it takes activity. Like, it takes time to learn to breathe diaphragmatically. It takes time to learn how to meditate, as an example. Okay. But what I want you to know is that these two branches of the autonomic nervous system, they work like a teeter-totter. So again, stress kicks in sympathetic nervous system. And then if the person has chronic stress, it keeps kicking it in, kicking it in, kicking it in. That person like, they're experiencing all of that from that. But when we deliberately turn on the parasympathetic nervous system, like diaphragmatic breathing, like with meditation as an example, like using imagery, the pregnant woman, Tammy, in the new medicine, her doctor, Dr. Tracy Gaudet, was using imagery to help her relax and preserve her energy and keep her from getting infected so that her baby could make it to viability. Her baby was able to make it to where his lungs had matured in the new medicine. If we deliberately turn on parasympathetic nervous system, we by default turn off the sympathetic nervous system. Okay. So strategically, what we're going to be doing for ourselves, or what we'd be doing if we are counseling our patients who are experiencing consequences from stress, we're going to teach them how to deliberately and regularly turn on the parasympathetic nervous system. And you saw that modeled for you in a couple different places in the new medicine documentary. You saw that modeled for you with Tammy, the pregnant woman, who her placental membranes had broken. The young woman, I can't remember her name, with the blonde ponytail, who was the softball player, who had chronic pain and depression. They were using more of diaphragmatic breathing for her. You saw in the young man that had herniated disc in his lower back. His insurance company sent him a CD that he was listening to that had relaxation and imagery in it, and he was able to use that and then heal from his surgery more quickly. So this stuff really works. If we train people to turn on parasympathetic nervous system and do it on a regular basis, they're experiencing a lot less stress, better physical health, better mental health. So this is some good stuff. Anybody have any questions here? Okay. Okay. So across history, we've done a lot of different things to try to measure stress. And for those of you who are psych majors, you know that psychologists are obsessed with measurement, because we have to measure things and measure things well in order to study psychological and behavioral phenomena. The first scale that was ever invented to measure stress was called the life event scale. And you would add up, if these events that happened to you, they were attached to levels of points. And the higher your score, the more points you had, because the more stressful life events you'd have, a higher score was expected to predict physical and mental illness. And at the top of the scale was death of a spouse. Like, that was supposed to be the worst thing that could ever happen to a human being, was the loss of a spouse. And then changes in medical status, you'd get about 50 points. Becoming partnered and becoming married to your partner would be 60 points. It's life change. And in the early research, they gave a bunch of soldiers this scale and they rated their life events. And then they predicted illness. Let me see if I've got this in the next slide. No, I don't. Let me go back. And they found a very small positive correlation between the total score on the scale and later illness. So very small positive correlation. But I want us to critique this. Death of a spouse, this happened to somebody that I know here in town. She goes to work one day, her husband goes to work one day, he gets in a horrible motor vehicle accident on the way to work and he dies. And he was in his young 40s and it was absolutely tragic. You know, left a wife, left children, the family was without 50% of their income. It was just absolutely tragic. Do we think that event, death of a spouse, would be very different than, let's say, I've been nursing my partner in old age and my partner's been declining and in pain with horrible cancer side effects and is wanting to die, is ready to die. And when that person passes, it's like, and if you believe he's going to heaven, that person passes and it's like, finally, there's some relief, right? That would be experienced very differently, right? Same kind of thing for unplanned pregnancy. Unplanned pregnancy for a woman in her mid-30s who has been trying and trying and trying to get pregnant and then just gave up and then gets pregnant. That's a miracle. Unplanned pregnancy in a 16-year-old whose significant other just left her. Is that a miracle now? No. That's now a tragedy. That's going to be incredibly stressful. Yeah. Okay. So what I'm getting at is these scales, when we just measure these life events, they don't get at one's personal perception. It doesn't go through our own circumstances and our own perceptions here. Here's one. I just wanted to show you this undergraduate stress questionnaire because I think a lot of you can relate to this. Add on pandemic, and we've added a whole nother layer of stress for a lot of individuals. Certainly death of a close family member, very, very stressful. Lots of tests applying to graduate school. Some of you might be going through that, being a victim of crime. Lots of things that are uniquely stressful to college students. Going into a test unprepared. I still have nightmares every now and then. And then whenever I have these anxiety nightmares, I go, I must be experiencing some stress. But I'm back in high school and I'm going to take a test and I've not studied for it and I can't even remember the subject. And it's like, it's just stupid. But it's that going into a test unprepared, which I never did in my life, which is why that particular dream is very stressful. Okay, so now let's go into Lazarus and Folkman's model of stress appraisal. Lazarus and Folkman say, and we know this, we've done enough research to know this to be true. When we experience stress, we're actually going through two very quick processes back to back very quickly. And the first is primary appraisal. And primary appraisal is us determining, is this event, is this particular stimulus that I'm experiencing, is it threatening, or is it pleasurable, or is it neutral? If we deem it to be threatening, then we move into secondary appraisal. If we deem it to not be a threat, okay, then we're done, no stress. Okay, we exit the model. But if we find this stimulus or this event to be threatening, then we move into secondary appraisal. And in secondary appraisal, it's, can I cope with this? Do I have the skills? Do I have the resources? Do I have the support to be able to cope with this stressful, threatening thing? Now, most of us do this primary and secondary so quickly that we don't even realize they're two separate processes. But clinically, when we're working with people with consequences from stress, we help break this up. And the how threatening is the event is going to be more cognitive therapy. It is taking their stress perception in their mind and how they think about it in their automatic thoughts, how it is rooted in their beliefs and their values. And we try to help them change the appraisal so that it's not so stressful. So let's say I am a worker and I'm overwhelmed with my workload. and my boss comes along and dumps another big project in my lap when I'm already overwhelmed, that's a threat. And then I'm like, oh crap, I can barely get my work done as is. Now my boss is putting me in charge of this other big project. How on earth am I going to get that done too? One way of changing that appraisal process would be, let's say I've got a client and they're telling me this story about their workload and their boss giving them this project. But I've heard this client say over and over again, I really want to get promoted, and I really want to get promoted and have that raise and get that extra money. Then we might take that project that this boss decided they were capable and responsible of leading that project. Isn't that a compliment? In some ways, your boss picked you, your boss didn't pick the other 10 people that your boss could have picked. And might this be the opportunity for you to lead this project and show how good a leader you are? And then maybe if all that goes well, then you can sit down with your boss and ask for that promotion and ask for that raise. Does it make some sense? So you're taking the stressful thing and you're trying to change the perception to alter it to something a little, going from the pessimism to more of the optimism. And again, sometimes positivity and optimism are overrated. Sometimes we just take the negative stuff and we try to get people to neutral, because at least neutral's in the middle, okay? In the middle between negative and positive. So primary appraisal is going to be the cognitive piece. The secondary appraisal is going to be more skill sets. And when I think about helping people cope with stress, I think about, and we do this in therapy all the time, we help them create a toolbox. And the key to the stress coping toolbox is to have multiple tools for multiple things. So being in financial debt would require problem solving. Loss of a loved one, it would be more of an emotion focused coping type of thing that's going to ideally allow people to grieve, as an example. Okay. So we build that toolbox, and then the challenging part is helping clients to know, what tool do I need for this particular problem versus a different kind of tool that I would need for another kind of problem. So if the only tools in your toolbox are one nail and one hammer, then that person's probably going around the world going, okay, every problem needs to be a nail hammered into something. When what if they need a screwdriver? What if what they really need is a wrench, as opposed to just a hammer and a nail? I'm about to launch into a Indigo Girl song here. Make some sense? So primary appraisal is cognitive. Secondary appraisal are coping skill sets, and we can help clients with both of those. Okay. Questions here? I want you all to think about this for your lives. I want you to think about things that, say, recently have been considered really stressful for you. And what was your primary appraisal process like? And did you shift that at all, or did you just let it roll? And then did you have the particular skills to cope with that problem? Okay. Any comments, questions? Anybody? Okay. Okay, so again, here's what the model looks like. You got the potential stressor. You go to primary appraisal. If you exit the model, it's not a threat. You're out of the stress. If you go, oh, this is a threat, you go over to secondary, and then determining if you've got the skills to cope with it or not. Okay. So these particular characteristics of stressful situations, and I'm sure a lot of you are going to be able to relate to these. This is going to seem very intuitive as we go through it. But when we're helping people cope with stress, these are some of the things that we will look into and we will assess, and then we will have deliberate strategies for helping them depending on where they fit with this. Life transitions tend to be stressful. Many of us just can even relate to what happened last March. A dramatic life transition for those of us at ASU. Spring break got delayed, pandemic, everybody was put on lockdown, that kind of stuff. So we have all had this sort of unified life transition during the pandemic. Going off to college, becoming a new parent, kind of like I talked about the fever example, having to relocate, the demise or the ending of relationships, I've known quite a lot of individuals that have gone into retirement and then come out of retirement because it didn't suit them very well. They didn't have enough resources or enjoyable things to do or meaningful things to do in retirement, and then they've gone back into the workforce to have more meaningful things to do in their daily life. So life transitions, difficult timing. Again, I'm going to use a woman's example here: an unplanned pregnancy for a woman who's not ready to be a mom at age 15. I have also known, thank goodness this didn't happen to me, but I've known a lot of professional women who are my friends who delayed reproduction. They waited and waited and waited because they wanted to get their education, they wanted to get their career launched, they wanted to get financial stability, have time in relationships with a partner, to build up trust, that type of thing, and put off trying to get pregnant until later in life, like past their 30s, and then stop the birth control thinking, oh, this is, I'm going to be pregnant next month, and then no pregnancy, no pregnancy, no pregnancy, and realizing at that point in time they're struggling with infertility. And a lot of doctors can't necessarily tell, were you having infertility issues all of those years, or is this a function of age for women? And men do have declined fertility with age, but women really hit. And it's right around the age of 30, a dramatic decline in their fertility. And by age 35, a tremendous decline in their fertility. And at age 35, now we're building up risk of having a baby that has Down syndrome or spina bifida, which is why pregnancies over the age of 35 are considered to be high risk pregnancies. And there's lots of genetic screening that's done for women, that kind of thing. And somewhere in this, for heterosexual women, I know this doesn't apply to gay women, but there's just a lot of women really trying to control their reproduction if they're in a heterosexual relationship across their lifespan. And so we mentioned that as a unique women's issue the other day. Ambiguity. We don't like ambiguity. We don't like uncertainty as human beings. And people who are high in anxiety sensitivity especially don't like ambiguity and uncertainty. And so an example here would be, and you all have known people who've been through this in the healthcare system, people having symptoms, being distressed, going to a doctor runs tests, you have to wait for the test results, you get the test results back. Sometimes they're reassuring, nothing bad's happening. Sometimes the tests are like, ooh, something bad's happening here, we need to run more tests. There is a lot of patients in our healthcare system experiencing a lot of stress just because of this kind of ambiguity and uncertainty. Okay. And again, if we're healthcare providers for individuals that have access healthcare, we want to provide individuals with a lot of understanding of that, of like, yeah, it's hard to wait for those test results. And yes, it's hard to get the test results if they're bad. And then it's hard to figure out, okay, what treatment do I want to do or not want to do? Is this terminal? Might I be dying? And how stressful that could be for individuals. So there's a lot that we can do to be helpful here. Low desirability events. This is going to make sense. Losing a job unexpectedly. We talked in the last class about how many women have had to leave the workforce to stay at home and care for children during the pandemic. That's certainly a low desirability for women who very much enjoyed their careers and enjoyed that income, and found meaning in what they were doing. Being a victim of a natural disaster, and then just little kind of stuff like a traffic ticket. And then events that are low in controllability. So having a medical illness that the person is not able to manage or control, like chronic pain. A person with OCD who's had a traumatic event, who can't stop intrusive memories or can't stop obsessing about something horrible that could happen or has happened to them. Low controllability spins out a lot of stress. There's even research, as an example, in nursing homes. If in a nursing home, you have people in generic beds with roommates, serve food that they don't get to make selections. They don't get to decorate. They're not allowed. This is happening during the pandemic. They're not allowed visitors because of fear of spread of germs. Those people in that nursing home are going to be in a lot of stress relative to, let's say we had a nursing home that operated where you have your own bedroom, but you can go out into common areas and socialize. You can bring your own linens. You can wear your own clothes. You can decorate your room. You can bring in plants or flowers or whatever you want. You can have visitors whenever you want. They give you a menu every day and you get to select from the menu what you would like for breakfast, lunch, and dinner. That's going to be a very different experience for that particular nursing home care patient because they've got controllability. There's some fascinating anesthesiology research that shows, and some of you may have known somebody who had a device like this when they were in the hospital. If you give a patient in the hospital who needs a narcotic for pain control, if you give them the device, they hook them up to this little device where they've got the narcotic, and whenever their pain is starting to get really painful, they can push a button on the device and then they get a dose of the pain med immediately. Now, keep in mind, these devices, you can't, if you're a patient in a hospital, you can't sit there and push and have yourself a narcotic party. You know, it's not like, woo, you know, let's get a high off of this. You can't keep doing that. It'll only work on every so many intervals. Those patients who are able to self-administer their own pain control use less medication than the patients who have to call a nurse. The nurse might have to go look up the doctor's order for that medication, and then the nurse has to bring it in a pill or bring it in a shot or put it in an IV. Those individuals end up using more pain medication because they've got less controllability over it. The people that have the device for it, they've got a lot more controllability. It's sort of like, it's kind of like how I feel about having chocolate in the home. It's like, I don't need to have chocolate all the time, but it sure is a comfort to know it's there when I want the chocolate. You know, it's sort of like, you know, if my pain gets bad enough, this is what I'll do. I've got the controllability here. Does that make some sense? Okay. Okay, one more slide and then we will call it a day. So there's a book that was written, it's called Bowling Alone Effect. And what this particular book is about, it's the idea that individuals are doing more things alone. You add to the stress of the pandemic and the lockdown, and people are doing even more things alone than pre-pandemic. And it's also the idea, like, did anybody in here, just shout out yes, did any of your parents belong to a bowling league? I'm going to shout out yes. My parents were in bowling leagues. They had the jackets, they had the shoes, they had their own personal bowling ball. They would go and drink beer with their friends and play and compete in bowling once a week. It was this big social event for them. Okay. So the bowling alone would be nobody goes to a bowling alley and bowls alone unless you're like professional and you're practicing that kind of thing. So it's a little bit of what has happened in modern day times, in my generation compared to my parents' generation, in your generation compared to my generation, where a lot of individuals, particularly if you get a college education, you go to where the jobs are and move away from extended family. So I've used the example of having a newborn. It is so much easier for people with newborn and toddlers if they have extended family around. Okay. So let's say my mom and my dad lived next door when I had a newborn. Boy, they could really have helped me out a lot versus them living 7 hours away, as an example. Okay, so this happens to a lot of individuals. More reliance on social media. And I'm curious in here if we can do you all know that you can click and do a yes? You can actually click a yes through your reactions. How many of you in here feel like social media brings you closer to others? Give me a yes. Let's see if I see any. I should have created a little poll. We've got, yeah, at least one person I'm seeing saying yes. Versus how many of you feel like social media distracts you from close emotional intimacy and closeness to others. Yeah, we're hearing a lot of that nowadays. For some individuals, it brings them closer, and for a lot of individuals, it kind of pushes them away from real life interaction. Again, you throw in a pandemic, and we've got a whole another ballgame that we're dealing with here. The amount of negative information that we are exposed to in daily life. And I think about this, when I was growing up, it was a ritual with my parents. When my boys were growing up, it was a ritual with me every evening. We would have dinner and we would sit down and watch a half an hour of the national news. And it was like a comfort. We had the same anchor who would, give us the national news. And it tended to be rather unbiased back in that day. And it also tended to be, there were, the negative stuff going on and the feel good stories. And it was just like this kind of comforting, half an hour of the evening. Nowadays, on the other hand, we've got these news networks that are trying to keep your attention around the clock. And we know a lot of people who are shut in, whether it be pandemic or they're shut in because they're elderly, where if they've got the TV turned on all throughout the daytime and they're being bombarded with this negativity. And then news recently, and this has been your generation only, I feel for you young people thinking like this is how it's always been, because it hasn't always been this way. The nastiness that we're seeing, of just the infighting and the nastiness and the disrespect and that kind of thing. Whoo, I never saw that on the nightly news when I was growing up or my boys were young, kind of thing. That's really harmful. When I work with people who are stressed, and particularly people who are depressed, I'm like, and I ask them how much social media they're consuming, and I ask them how much of the news they are consuming, and I will oftentimes encourage them to take a holiday from social media, take a holiday from news, and just live in their own little world for a while, because it is usually very negative information. And then the final thing I want to leave us with is that our human emotions, there is never, ever, ever anything wrong with any human emotion. There's never anything wrong with laughter. There's never anything wrong with grief. There's never anything wrong with sadness. There's never anything wrong with jealousy, anger, all of that. Where we get ourselves into trouble is taking these naturally evolved emotions. When we have unhealthy coping behaviors for those emotions, like we're drinking and drugging to escape feeling sad, as an example, or we are snapping at our kids because we're feeling irritable, or feeling like somebody just stepped on us and rejected us, and then we yell at our kids, kind of thing, and then the kids go and kick the dog type of scenario. I know that's horrible, but if we try to escape our negative emotions, or if we try to bury our negative emotions, that's where we get ourselves into trouble. Okay. Instead of feeling the emotion, processing the emotion, getting past the emotion, the best way is to feel it, sit with it, process it, grab our tool from our toolbox to cope with it. We're going to be in much better shape if we acknowledge our emotions, we process them, and we use effective tools to cope with them, than people who try to escape their negative emotions, or people who try to just bury them. What happens when you try to bury them? They come back with a vengeance. Okay. So think about your own lives or people you know, and see if you can kind of relate to some of that. A couple of years ago, I had one of my kitty cats got diagnosed with on a Thursday, got diagnosed with a heart condition. I cried myself to sleep because I was really worried my little foo-foo kitty was going to be dying. She actually lived for a long time after that, but I didn't know that then. The next day, my neighbors come over, and my big, huge Maine Coon kitty, we thought was dead under their bush. We get the kitty out of the bush, and he's in respiratory distress, and we had to go take him in and have him put down. I cry myself to sleep that night. The next day, I can't stop crying. I've got this one kitty who I think is dying because she's ill. We had to put another kitty cat down. My family's starting to worry about me at that point in time. Like, I've been crying for days, days and nights at that point. I wake up that Sunday morning, and I wake up and I announce to my family, I'm good. It's like, I got, like I had no fluids left in my body. So it's like time to rehydrate. But it was that, like, I needed That's what I needed to do. That's what I needed to do, was to grieve and to worry, and then be able to move past it, if that makes sense. Okay. It would have been a whole different kind of couple of days if I had tried to pretend that all was well and I wasn't sad and I wasn't worried. Make some sense? Okay. All right. Any questions before we finish up today? Okay, feel free. I've got my office hours today from 2 to 5. Feel free to pop in my office hours. I may go sit outside because it's so lovely with my laptop. So feel free if any of you all want to pop in, ask questions, or say hello. Okay, let me do. All right, good to see everybody. Take care.